All right, today we're going to dive into a topic that's a real blind spot in the stroke workup for a lot of people: aortic atheroemboli. It's this hidden source of stroke that can be hiding right there in plain sight. And by the end of this explainer, you'll know exactly how to find it. So let's just start with a super common clinical scenario. You've got a patient who comes in with a stroke. You do the whole workup, right? The echo's clean, the carotids look good, but you still don't have a source. So the big question is, where do you even look next?
Well, to answer that, first we've got to survey the territory. Before we can track down this sneaky culprit, let's just do a quick refresher on the aorta's most well-known dangers, the big ones we all learn about.
So, at the very center of all this is the aorta. It is the body's biggest artery, no question. Think of it like the main highway, or maybe the main pipe in a really high-pressure plumbing system. Its job is to get oxygenated blood everywhere. So you can imagine when something goes wrong with it, it's a very big deal. Now, when you're in training, you hear a ton about the big two aortic emergencies. On one hand, you've got aneurysms, that dangerous swelling or ballooning of the aortic wall. And on the other hand, you've got dissections, that terrifying tear in the inner lining. These are the life-threatening catastrophes we are all trained to spot right away. But what if the cause of our patient's stroke isn't one of these huge, dramatic events? What if it's something quieter, something a little more subtle, hiding right under our noses? Well, this brings us to the real subject of the day, the unseen threat of aortic atheroma. That's right. It's not always the big, headline-grabbing emergency. Sometimes the real culprit is something that seems much simpler: a treacherous buildup of atheromatous plaque sitting right inside the aorta itself. So, what exactly is an aortic atheroma? Well, the definition is pretty simple. It's just an atherosclerotic plaque, the exact same kind of gunk you'd find in the coronary or carotid arteries, but it just happens to be located in the wall of the aorta. And here's the really crucial part. If a patient has it here, you can bet they probably have it in other places too. And this is why we have to talk about this. The evidence is just crystal clear on this point. The number one complication of these plaques is systemic thromboembolism. That means little pieces can just break off, get shot through that high-pressure system, and cause a TIA, or even worse, a full-blown stroke. But wait, how does a stable chunk of plaque just suddenly turn into a projectile? Well, you've got to understand the mechanism to really appreciate the danger. So let's break down this embolic cascade. Okay, so it's really a four-step process. First, the atheroma forms. Then, over time, some inflammation makes that plaque unstable. After that, a little piece of the plaque, or a clot that formed on top of it, just breaks right off. And finally, that little embolus travels downstream until it gets stuck in a smaller vessel, in the brain, the kidneys, wherever. Now, this is a super important point. We absolutely need to know which plaques are the dangerous ones. Not all atheromas are taking time bombs, but some of them definitely are. And the research gives us two huge red flags to look for on imaging. First, you're looking for plaques that are thick, specifically with a diameter greater than 4 millimeters. And second, you're looking for plaques that have a mobile or kind of wobbly component. That makes them way more likely to break apart and cause trouble. Seriously, if you remember just one number from this whole thing, make it this one: greater than 4 millimeters. That's the magic number. That's the threshold where the risk of an embolic event just skyrockets. Okay, so if these things are so dangerous, how in the world do we find them? Well, the funny thing is, the story of how they're discovered is often just pure chance. Yeah, the reality is you usually find these completely by accident. A CT scan for some belly pain, an echo for a heart murmur, and then boom, there it is. And this incidental nature is exactly why it stays such an under-recognized source of stroke. This leads to a really important clinical question then. When you stumble upon one of these plaques, what does it actually mean for your patient's overall health? Is it just a local plumbing issue? No, not at all. It's a huge deal. Finding an aortic atheroma is considered a coronary artery disease risk equivalent. So this isn't just a finding, it's a diagnosis. It's telling you that this patient has serious systemic atherosclerotic disease, and they carry the exact same level of risk as someone who you already know has blockages in their heart. And knowing that changes everything. We can't just write it in the chart and move on. We have to do something about it. So, what's the right move? What's the therapeutic strategy?
Well, the management plan flows directly from its status as a CAD equivalent. This means getting them on antiplatelet therapy, like aspirin. It means starting a high-intensity statin to try and stabilize that plaque. And it means being super aggressive with all their other risk factors: blood pressure, diabetes, smoking, the whole shebang. And this right here is the core philosophy. You aren't just treating one little plaque in the aorta, you're treating a systemic disease. The atheroma is just the fire alarm, and the real goal is to lower the patient's total cardiovascular risk to prevent future strokes, heart attacks, and everything else.
So this brings us all the way back to our original mystery patient. For every single stroke that gets labeled cryptogenic, meaning we don't know the cause, we really have to ask ourselves, could this be the hidden source? It's a question that should challenge us to look a little bit deeper and to really reconsider the aorta in every single workup. Thanks for tuning in.